this is a joint venture between LabLogix Limited and HuQAS in terms of training and capacity building in this field of andrology. There are going to be two of us, so I'm going to start off with the first part of the presentation, and we'll confine ourselves to the 20 minutes allocated time. We try to be fast. So I'll be dealing with andrology as it pertains to the lab and ordinary labs, and also to the IVF labs. And my colleague Julius will come in, because there's an aspect we are also looking into with regard to early detection of male infertility. And Julius will be coming in to give us a little insight on how we can use molecular techniques to enable us achieve that. So andrology, broadly speaking, andrology covers two main areas. One is urology, and the other one is reproductive health for the men. So, and in urology, for our purpose and for the work that we are doing with HuQAS, we are not really concentrating on that, but still is an issue, just as much as the reproductive aspect of this. And we find that the reproductive aspect for men in particular, because as men, usually we believe when it comes to getting children that we are okay. The problem is are our ladies. What reason do we give? The reason we give is that we have children out there already, but the problem is that we are not sure whether those are really our children. But do we care as men? So where the rubber meets the road for men, therefore it is in this andrology. And usually when it gets to a point that I realize that indeed the problem is me, it comes with a lot of psychological problem. You know, childbearing is a big issue, not just to you as a couple, but it can extend down the line, your parents, our grandchildren. So it becomes psychological torture to the couple, and issues can build up because of that. Now, there are areas also that we could also want to consider when you're talking about andrology, because this is also an hormonal function, the endocrinology, particularly the testosterone, the LH, the FSH. So some of those play a key role, and you would want to know, and that's why, I'll touch on it a bit, that's why we are thinking of possible tools for early detection of male infertility. So for this workshop, we are going to concentrate mainly on the male reproductive system with respect to semen and its quality, and the urology part of it is not for us to consider here. As I mentioned, this is a challenge, and as the men, we normally say that we are not a problem, but you can see that statistics, it's about 30%, I think is probably higher. Some reports have it at around 40%. But why would this be? It's because the first reason is that men don't present themselves whenever they go for whether there's a problem. It's usually the wives, the ladies who go to see the gynecologist and all that. So the data we have, probably worldwide, is not sufficient. So that is why this is low. If we are to test everybody before marriage or during marriage, probably this data might go up. So that could be a contributor to that. The other thing that is also an issue is that labs do run seminalisis, and probably you also do it at your places. But there are various protocols. At times, even myself, at times when somebody gives me a report and I look at it, at times I can't interpret. The reason being that there are several protocols that are in use. Others are instituted by the individual labs. But there are two good protocols. WHO actually has invested a lot of work into this over the years, and they've come up with protocols, first edition, second edition, third, fourth, fifth. Now I think there is a sixth edition, which are very good. But then there's also another protocol from South Africa. It's called Tigerberg Strict Criteria, which I also like, but is highly, highly strict. Its basis is on the fact that if a sperm cell is borderline normal, it is abnormal. So they are very, very strict, and the criteria is very high compared with WHO. So there are some labs I know and associate with that they don't take the WHO criteria. They only take the Tigerberg criteria. Tigerberg is a hospital in South Africa. In the labs where you work, there are a lot of advancement in technology. But when it comes to semen analysis and that kind of work, you find that still we are manual, just like in microbiology, and hence the need to have regular training, refresher training, and all that for an improved report. And that is why we are trying to fill that gap. The requirement at times, if you're just doing basic semen analysis, and you have a level 2 laboratory, you would probably be having sufficient equipment and materials to enable you set up a section within that lab that can effectively run a seminanalysis. So the basic requirements, as you can see them there, yes, microscopes and all that, this is probably you probably have. The only thing is the training. Yeah, do you know how to tell whether this is a good cell or not? And when it comes to that, therefore, we consider the various parameters. Again, these parameters, when you move from one lab to the other, they get diverse, and you find that you get a report from me or from another lab. At times, even doctors are not even able to interpret them very well because they are so different. First of all, based on what I said with respect to the criteria that each lab might be adopting. But key to me is the sperm cells, the numbers. Do we have a sperm cell in my sample or in that sample you are handling? And it's not a question of quality, yes, it is there or not, no. It's a question of what is the numbers. So we look at the concentration and we look at the total testicular output during an ejaculation. That will inform us whether that sample has good quality. We're looking at motility, and you can see motility, they have put progressive motility. We're looking at a sperm cell that can move from point A to point B. Point B, that's where the egg is. So that motility is critical, and we at times even grade them. Then, of utmost importance is the morphology. That is the capacity of that sperm cell to be able to bring about fertilization. And this is where actually the problem is. And because to be able to tell that this is a good sperm cell and this is not, because a lot of them will be moving, but not all of them will be able to fertilize. Vitality and morphology, at times people confuse, but they are two different. So morphology is to do with capacity of that sperm cell to fertilize the egg, and vitality is just telling you whether this sperm cell is alive or dead. So at times a sperm cell may be not moving, but it is alive and it has the capacity to fertilize. If the morphology is good, because the tail at times it just serves a purpose to propel the cell to where it is needed, where the egg is. And then there are also a list of other things which are equally important, but they will definitely impact on the above. Morphology is repeated there. Semen volume, pH, agglutination, where the cells are attaching to each other, or aggregation as well. DNA fragmentation. At times the cell looks good even morphologically, but apparently the DNA has been fragmented, and we have tests to determine whether DNA has been fragmented. And if the ratio is so high, then that's probably why you have good numbers, good motility, good morphology, but inside there, the DNA cannot function. So sperm penetration cervical mucus, this is about compatibility. You find that for myself and my wife, we cannot get a child, but with another lady, we can, or my wife with another man can. At times, so we do what is called cervical mucus interaction, issues of antibody antigen on the sperm cells and the like, and the cervical mucus, and the liquefaction. That is just to tell you how that cell, that semen will quickly liquefy, which is the recommended state before you even analyze it. When you have the sample, it's critical how this sample is handled. Sample collection, how it is collected, when it is collected, after how long the gentleman has been abstaining is critical. Some of the collection bottles are in themselves cytotoxic, and you put the cell there, the sample there, it gets to the bench, the sperm cells are not moving, they are probably dead or gotten immotile simply because of the collection bottles that we are using. Some even when they do collect from home, how do you transport that sample from home? Do you give adequate instructions? Yes, if you are to allow the sample to be collected from out of the clinic, what kind of instructions must you give before that sample gets into the lab? When you have it in the lab, how are you keeping it in the lab there? Do you have an incubator at 37 degrees Celsius for the sample to be able to stay in good condition? So management of the sample is critical. And when now you advance your techniques and procedures to the extent that the sample you are handling can be used by a clinician to do various procedures. You can see there, some are simple procedures, others are very complex, requiring IVF centers, but we do all that. So IUI, that is intrauterine insemination. Intrauterine insemination is where you prepare the sample and hand it over to the clinician, and the clinician will do what we call artificial insemination when we're dealing with the cows. So that's what. So the other one is IVF. So IVF or ICSI, both of them are actually IVF, in vitro fertilization, and ICSI is intracytoplasmic sperm injection. IVF, so remember the very first talk about test tube babies. So that's when we prepare the sample. It's not being used for IUI, but now we upscale it to the IVF labs. I think now there's so many in Nairobi. We have so many labs. Like in a day, I can move through like about 2 or 3, and the sample, the sperm cell, is then handed over to an embryologist, who will then either perform a straightforward IVF. Straightforward IVF is you have your egg there and you have the sperm cells in the tube. Of course, it's not a tube anymore. It's a small petri dish-like. You have your oocytes in there and you have your sperm cells there. Let them play their game. Tomorrow you come, you check whether any fertilization has taken place. You have an embryo and monitor your embryo. After you've gotten the right blastocyst, you can again hand over that, the embryologist hands over that to a clinician, who then transfer the embryo back to the recipient, who in this case would be most likely your wife. ICSI is when even IVF is not possible because of the very poor quality of the sperm cells, or the movement, motility is bad. So ICSI now, the embryologist literally chops off the tail of the sperm cell and immobilizes it after he has that embryologist has assured that this is morphologically sound sperm cell, and inserts it into the oocyte, and you get your fertilization, and everything proceeds from there. There are two methods of preparing the sperm cells. There is the gradient preparation and the swim up. Both of them, you achieve the same purpose. The only difference is that the swim up, you let the cells swim up and then you harvest them. The gradient, you have a gradient layer, you place your sperm cells on top, the semen on top, and centrifuge, and the sperm cells will be forced to the bottom of the centrifuge tube, and you pick them from there, wash them up, clean them, and you get a good harvest of your sperm cell, concentrate it, hand it over for IUI, IVF, or whatever purpose. At the bottom there, and process samples. The fresh semen, so let's say if you just gotten the sample, that sample, you do not hand it over to the clinician for the procedure for various reasons. The seminal fluid has a lot of substances, some of which are not good for for fertilization, and at times it even irritates the recipient. So that's why it is required that the sample must be prepared. If you must do that, if you don't have the reagents and the necessary equipment to do the sperm wash and all that, then you can resort to, it's now not IUI, but it becomes IVI. IVI is intravaginal insemination, which means you put the clinician will put the sample way down below the cervical mucus. But that one, I think the men can do it better. Yeah? So the sperm cell will swim up there. So fresh sample is not, you can't use it for IUI. It will not get good results. Now, whenever, if you have your sample and you don't have any sperm cell in the semen at all, and if it is possible that the testis has the sperm cells, but they cannot come out in the ejaculate. Either you have they flow back, what we call retrograde ejaculation. It goes back during ejaculation, the sperm cells goes into the bladder and they are of no use. Or there is an obstruction on the tube that gets them out. You get your seminal fluid because that comes from the prostate gland, but it will be devoid of any sperm cell. So we do what is called TESA, that is testicular sperm aspiration. So again, the clinician goes into the testis with a syringe and takes a small portion of that, and we check to see whether there are some sperm cells in there, and we are able to use that. Now that will now be used for basically IVF or ICSI, but largely ICSI, but at times we get very good harvest with that. Yeah, especially if it is because of obstructive azoospermia. But if there are few, ICSI will do, because ICSI you only need as many cells as you have in the, as you have the oocytes. And the oocytes, at times when we do the retrieval, we retrieve on the region of 10 to 20. In most cases, if you superovulate well, you can get even 30. And that's but still 30, even with low count, you are talking of low counts, but you're talking in terms of hundreds of thousands of sperm cells or millions. So you see, you have, for ICSI, you have enough for that kind of work. We also advance this further in cases where maybe an individual might be going for medical treatment, radiotherapy, chemotherapy. The individual, and in other countries, if you are a military man and you are going to war and nobody knows whether you're going to come back, you are required to keep your samples. We now have sperm banks, quite a lot, many of them, for personal samples. And also, if I am the problem, but we still want to have children with my wife, but I cannot fertilize the egg, then we also have donor programs. We have sperm banks. So what we do, like if you come to our place, we have a profile. Do you want a tall guy like me or a short guy? And the complexion, the community, So we have the profile. We don't show you the picture. Of course, there's the problem is if I don't show you the picture, maybe it's your brother or it's your close relative. So those are the challenges. That's why there's the legal and ethical considerations. Okay. Now, on sperm freezing, even before I move to this, so sperm freezing, we have protocols for doing that. You can freeze the sample for 1 day, for years. We have samples that we froze in 2005, and they're still very good when we thaw them. They're good to go for IUI and for IVF. Now, this is an area that HuQAS is heavily good at, and that's one of the reasons why we are partnering with them, because we want laboratories that can produce good results, and QCs like Martini has talked so much about this, is essential. So there's no point establishing or helping a lab to come up with the andrology unit, and then we don't follow up. So EQAs, we are coming up with this. Currently, most of the EQAs that probably you people have are dry slides. Those ones are good. And dry slides, you can only do them for morphology and vitality. Of course, we are going to provide that, but we're going to go an extra step to provide wet samples, because we need you to be able to tell us about the motility and to be able to tell us about the concentration. So you cannot do that without using wet sample. So we have worked out the logistics. We'll be delivering them to labs that already have liquid nitrogen system. Those ones will be good to go. But even if you don't have that cryopreservation facility, you're still good to go. Only the protocol is slightly different, but it will work. The moment the sample arrives at your lab, you quickly thaw it and read. This one now, I want to hand over to Julius for 5 minutes or less. And this is because when you look at morphology, what are possible issues that could lead to poor motility, poor morphology, and poor spermatogenesis and all that? Are there possible diagnostic for early detection? Because to get the sample, you cannot get a sample from a child. But if you have the other tools, that might help us, especially if you're getting the blood sample.
So I won't repeat about the definition of infertility, male infertility. In fact, I saw that ladies in the audience were more attentive when Hezbon was describing this. But then, yeah, the male factor is about 50% of the time. And then the other figure that he mentioned, about the 30%, which really is due to the male alone, and which he thinks is a bit higher. So the molecular method is just to use, when using molecular diagnosis, to study what genes might predispose one to have, inability or compromise the possibility of sperm being able to fertilize an egg. So there are about 3. I'll only give you 3. So there's one which is a mutation due to a gene called responsible for expressing cystic fibrosis. So when you have that disease, then you have a condition where the sperms do not mature well, and then leading to infertility. And then the other one is the number 2, where you can see you have an extra X. Usually it's an X and a Y, but in this case you have XXY, yeah, instead of XY. So you can use cytogenic test, karyotyping, to be able to see that. The third is a combination of those genes that are found on the Y chromosome, or just insertions or deletions in that chromosome, which then predisposes you to hormonal imbalances, or just how you make sperms. Or even for this particular one, you can also study the same in the female. You might find certain genes which also can predispose somebody to have a bad egg or bad sperm. So, and that one is studied by next generation sequencing techniques. So yesterday, Isabel gave you, there's a slide that she had which showed quite a lot of instruments or the workflow of coming up with DNA. So DNA is the molecule you start with. You make very good DNA, you quantify it, and you know, and then that's when you take it through PCR to amplify the region that has these deformities, or where you can see the insertions or deletions in the gene. And then she also showed next generation sequencing equipment. And that one is almost like you go until the PCR, and then when you reach to the PCR, then instead of just reading off the result of the PCR, you take it through sequencing using those big sequencers. They put a lot of chunk of DNA together. They do the PCRs to amplify the particular region that you think is compromising the ability of sperm to develop, and then use bioinformatics tools to do it. Yeah. So in all this, as I finish, we give a disclaimer that not all genes are expressed. Yeah, the way you think they are. You can have the gene and it's not expressed. The environment plays a big factor in regulating which genes are expressed. And to impose it onto this topic of andrology, you can probably use the words like prognosis, where you do a test before the detection. So you do a test and then you see, oh, this guy has a bad gene for this. Therefore, there's a likelihood that his sperms will not be good. I don't know whether that sounds... let's say like a couple. You know the genes that cause sickle cell anemia. So if the man has it, he's a carrier, right? If the lady has it, she's a carrier. When they have children, most probably you'll find one who suffers from the disease, right? Yeah, so it's almost like that. And nowadays people can do tests. People do tests to know that if I carry this gene, I'm likely to be this. It's a new method, and it is almost like telling you that you fall in love. No, what is it? How do I put it? Do you fall in love and test, or you test so that you don't fall in love? Yeah. So that is the question. Yeah. If you meet somebody, you like them, then you tell them, oh, we need to go and do this test to see whether you have sickle cell, whether you're a carrier of sickle cell. And then if you find that both of you have the carrier state, then you say, we are sorry, we just have to break up this relationship, because you're likely to have sickle cell anemia if you have children. So that is the whole gist of molecular testing. It's just looking at the DNA, what genes are there. If it doesn't have certain genes, or there has been deletions and insertions at that gene which prefers that characterism, then you know for sure that that is the cause for having the inability to produce good sperm. So thank you.